After the seminar, you are out to know what is leukemia, how does it happen, how to diagnose leukemia, what are the oral manifestations of leukemia, and how to manage a leukemic patient. All human blood cells are derived from one original precursor type of cell, the hematopoietic stem cell. These hematopoietic cells are immature and called blast cells. They are huge in size relative to the called later on blood cells and found in the bone marrow. Hematopoietic stem cells in general give rise to two types of cell, the common myeloid and the common lymphoid progenitors. From these progenitor cells, all types of blood cells are formed. So when does the blood begin? Well, sometimes the hematopoietic stem cells give rise to an abnormal, kind of weird, immature blast cell that does not function well. This weird cell is stuck in the immature stage and can happen at any point in the scale of maturation. Although this genetic mutation seldom happens, but when it does, it might be accompanied with another genetic mutation that urges this mutated weird cell to mutate and proliferate endlessly. Then we end up with numerous, plentiful, rapidly dividing, non-functioning blood cells, and these are the leukemic cells. These mutations may be the consequence of exposure to carcinogens, radiation, or an incident of chromosomal translocation. And now comes the question: if these weird cells are not functioning, why are they so dangerous? These weird cells unfairly take up other blood cells' space, growth factors, and nutrients, so in one way or another, they conquer the bone marrow. This leads not only to increased number of these non-functioning cells, but also to a decrease in the number of normal blood cells. The time of the mutation yields a special importance, as the earlier these mutations happen in the scale of maturation, the more rapid its replication is, and so the more acute it is, and vice versa. A mutation in the more mature stage renders the leukemia more chronic, which might be discovered after years. Overall, the process of how both develop is the same, and that is the mutation. In a typical way, this process might as well explain the signs and symptoms of the leukemic patient in general and irrespective of the classification. The reduced amount of red blood cells, so the low amount of oxygen delivered to the body, renders the patient looking pale and experiencing weakness, fatigue, and shortness of breath. The reduced platelets number leads to prolonged bleeding and easy bruising. The inhibited white blood cells function leads to a higher susceptibility to infection. And finally, as these leukemic non-functioning cells grow into the walls of the bone marrow and conflict with the nerve endings there, they cause general bone pain. To diagnose leukemia, initial complete blood count should be done. If this test shows abnormal number of white blood cells, then a bone marrow needle biopsy and aspiration of the pelvic bone to be done to confirm the diagnosis. Further diagnostic measurements are also used, but these are not the scope of this seminar. Leukemia in general, and in a broad classification, has 4 types. They are classified according to the nature and the acute cell type. So the 4 types are acute lymphocytic leukemia, acute myeloid leukemia, chronic myeloid leukemia, and chronic lymphocytic leukemia. ALL is the main cause of death in children, and it accounts for 75% of all childhood acute leukemia. Clinical manifestations of ALL are represented as common as fever and fatigue, while oral manifestations may differ and range from mucosal pallor due to reduced RBCs to gingival bleeding and ecchymosis due to reduced platelets count. But a persisting and consistent sign of ALL, and this is very important and critical, is the lymphadenopathy of the head and neck and lymphoid-bearing tissue of the orofacial region, and those are the tonsils. Patients may also develop laryngeal pain, evident in 52% of patients. Ulcerations and gingival enlargement are also evident. Treatment. Chemotherapy is 80% successful in pediatrics, but not in adults when the percentage drops to 40 due to relapse. Allogeneic stem cell transplantation, which is to collect a stem cell from a donor and transplant it into the diseased patient to restore some of his immune function, is another line of treatment. But this needs a matching donor and is preserved for patients at a very high risk. The use of tyrosine kinase inhibitors and chemotherapy is another frontline therapy. For adults and because of relapse, CNS prophylaxis and prolonged chemotherapy treatment is advised. The median age in AML is 66, and about 70% of cases take place over the age of 55, with unfavorable survival rates. Even with patients younger than 60 years, the curing rates are 40 to 45%. The most frequent oral manifestations of AML are bleeding, frequent oral ulcerations, and gingival overgrowth. And this gingival overgrowth is an early manifestation of the disease. Other signs are mucosal pallor and recurrent oral infections. Treatment: intensive cytotoxic therapy and allogenic CST, both of which might be combined in higher age and higher comorbidity groups. Now, with the chronic leukemia, CML has a less generally pronounced marrow failure than acute leukemia. Its course lasts several years. Average age of CML is 65, so it is mostly in adults, and males are more affected than females. CML follows indolent course for 2 to 3 years at first, followed by an accelerated phase of plasticrysis resembling acute leukemia. CML rarely has oral manifestations, and those might be presented as granulocytic sarcoma in the more chronic phase of the disease. Treatment of a chronic phase, which is the pre-blast phase, include the palliative treatment, TKIs, and allogenic CST. Median age in CLL is also 65, and 95% of the patients have slow clonal B lymphocytes accumulation. CLL is of two types: a slow-growing type that does not require treatment and has a 15-year survival rate, and another very serious, vastly growing type that has 8-year survival rate. Most people with CLL die because of the disease or the disease-related complications, like infection and secondary malignancies. 70 to 80% of the patients are diagnosed accidentally. Oral manifestations of CLL are related to an advanced stage of the disease, and most of the time cannot be utilized to confirm the early diagnosis. These oral manifestations include involvement of the lymphoid-bearing tissue, gingival and palatal region, and recurrent oral bleeding and palatal enlargement due to gingival leukemic infiltration. Medications such as purine analogs and the gold standard FCR are significantly effective. Median age in CLL is also 65, and 95% of the patients have slow clonal B lymphocyte accumulation. CLL is of two types: a slow-growing type that does not require treatment and has a 15-year survival rate, and another very serious, vastly growing type that has 8-year survival rate. Most people with CLL die because of the disease or the disease-related complications, like infection and secondary malignancies.
It's worthy to know that dentists bear the responsibility for initiating the diagnosis in 33% of patients with AML.
Are related to
So for that reason,
stage of the disease,
these manifestations
and most of the time
should
cannot
be
utilized
recognizable.
to confirm the early diagnosis.